So it's my great pleasure to introduce the second speaker tonight, Dr. Brooke Judd. Brooke has been part of Dartmouth-Hitchcock Medical Center and the Dartmouth Medical School for 17 years. After earning her MD from Chicago Medical School, she completed an internal medicine residency and fellowships in pulmonary and critical care medicine and sleep medicine at DHMC. She joined the DHMC staff in 2000, specializing in psychiatry, sleep disorder services, with a practice focus on non-invasive mechanical ventilation and obstructive sleep apnea. She currently serves as clinical director and began her academic appointment as an assistant professor of psychiatry and medicine at DMS. She coordinates training and curriculum in sleep medicine for fellows in medicine and serves as a case conference leader for second and third year medical students. She has written various educational brochures for the American Academy of Sleep Medicine, as well as several articles and book chapters for various publications. Please join me in welcoming Dr. Judd.
Thank you, Dr. Green, for inviting me. It's always very difficult to follow Dr. Satay. He's a tough show to follow. But we're going to talk more about some specific sleep disorders. He's done a great job with introducing us to sleep and why it's important and what happens if you don't get enough. So I think my time is, I'm a little short, so I'm going to try and get going. So we're going to first talk about some normal circadian rhythm of human sleep. We'll discuss some circadian rhythm disorders, and then discuss some of our most common sleep disorders that we see in the sleep lab. So first we need to describe what a circadian rhythm is. And again, as Dr. Satay introduced us to, it's basically our biological clock. It's a self-sustained, approximately 24-hour cycle, controls basically every biological process in your body. Every living organism has a circadian rhythm. Plants, single-celled bacteria, elephants, humans, we all have circadian rhythms. In humans, again, as we learn, the circadian pacemaker, or the area where that circadian rhythm is generated, is in a very specific area in your brain, in the hypothalamus. It's called the suprachiasmatic nucleus, or the SCN. And this area is what orchestrates all the other rhythms of physiology and behavior. And this is just a diagram that shows us. So the suprachiasmatic nucleus has rhythm outputs that go to other areas of the brain, such as the brain areas that control sleep and wake, controlling hormone levels, controlling other areas of your nervous system, blood pressure, temperature. These rhythms vary over 24 hours, and based on what this output is, shows us what kind of physiology and behavior we're going to have. So what sets your biological clock? Well, actually, you don't really need to set it at all. It's an intrinsic pacemaker. It doesn't require any external input. But actually, our intrinsic rhythm is slightly longer than 24 hours. And this was discovered by Dr. Kleitman, who is the father of sleep medicine that Dr. Satay spoke about, doing some experiments in caves, in the Mammoth Caves in Kentucky in the 1930s. They went down there. So when you're in a cave, you don't have any exposure to light or any cues to tell you what time it is. And that's how they figured out that your intrinsic rhythm is a little longer than 24 hours. So, as we all know, we function in a 24-hour society. So what we need to do to stay to that strict 24 hour is use some time cues to keep us entrained to that 24 hours. The most important cue that we use is light, although exercise and meal times are also important. So we're most concerned about how our sleep is controlled. And light is the most important thing for that. So light hits your eye, which is directly attached to your suprachiasmatic nucleus. Even in blind folks, even if they can't see images, a lot of the time their eye can still detect light. This impacts our sleep-wake. It also directly impacts that pineal gland and that melatonin that we talked about. So again, as Dr. Satay had talked about with melatonin, you actually start peaking your melatonin when light goes down. It peaks in the middle of the night, and then it starts to decline when light comes back up. So for most people, we start to increase our melatonin around 8 p.m. So now we can move into some specific circadian rhythm sleep disorders, and these are the most common disorders that we see. We'll start with a case. So this is a 17-year-old male that we're seeing. He has a 2-year history of an inability to fall asleep until 3 in the morning and difficulty waking up in the morning. He's been struggling due to difficulty getting up for class or staying alert in his early morning classes. He did previously have some good grades. He was placed on an antidepressant, but that didn't really seem to help his sleep. He tried melatonin at bedtime, but it didn't help. So is this a typical teen who wants to stay up too late and play on the internet, or does he have a sleep disorder? So actually, this is a pretty classic delayed sleep phase. And the problem in a delayed sleep phase is your circadian clock is reset. It just, instead of getting sleepy, what time do we most get sleepy? Most of us get sleepy 9, 10 o'clock at night. In a delayed sleep phase, people don't get sleepy until much later, 2, 3, 4 in the morning. As we become teenagers, there's actually an intrinsic shift toward a delayed sleep phase. So we tend to see this generally manifest in teen years. Is there an external component? Sure. There's a lot going on. There's, at the same time you're going into your teen years, you're also having more control over your sleep schedule. There's computer, there's activities, there's all kinds of electronics. But this is really an involuntary pattern of not being able to get to sleep because of a shift in the clock. The problem is that it can really interfere with school and work performance. So how can we manage this? There's 2 ways to think about it. Certainly, we could start school or work later. There are actually a number of school districts in the country, not here, but a number of districts have had later school start times, and this has been associated with improved performance, improved absenteeism. Actually, there are some schools that have shown less driving accidents in teenagers. Again, if it's not a teenager anymore, but an adult, they could start work later. So instead of trying to conform to a 9 to 5 schedule, work second shift or third shift, and we certainly have patients who do that. The other alternative is to try and alter the intrinsic circadian rhythm. So how do we do that? When we think back to those external cues that were helping with keeping us on a 24-hour schedule, and we can try and manipulate those. So again, as Dr. Satay talked about, melatonin is one of the things we use, light exposure and exercise. The very big key to treating circadian rhythm disorders is appropriately timed use of these things, because if you give them incorrectly, you can make the problem worse. And we don't really have time during this talk to talk about how we know when it's incorrect and when it's correct, because it has to do with monitoring your core body temperature, which is done by rectal probe monitoring, and nobody really wants that done. So we have ways of knowing. So we use melatonin, and again, it's a very weak sleep medication, but we can use it differently to try and help reset the clock. So remember when we looked back at that, where melatonin begins to peak, in somebody who has a delayed sleep phase, they're not starting to have their melatonin here. They're starting over here. So we need to try and move their melatonin back so that their brain is getting sleepier sooner, or tricking their brain by tricking their suprachiasmatic nucleus. Alternatively, light is another way that we can help try and change how your circadian rhythm is set. Light is activating, so melatonin makes you sleepy when it's timed correctly. Light and exercise, but mainly light, are activating. Again, we want to expose in the morning. We actually need to be pretty careful about the timing of when we do that, not do it too early, because it can make the problem worse. What's the problem with this? The problem is it's actually very difficult to move your circadian clock back. To some degree, it's just sort of who you are. When it's really severe, when the problem's really severe, we usually really can't get it back more than 2 hours. The other problem is you have to be very consistent with the schedule changes, and this can be really difficult in a teenager. You can go through all this, get them on the melatonin correctly, the light correctly, get them on a regular schedule. If they decide Friday night they're staying up till 4 in the morning, it's over. They're back at square one. So it's a problem, and we see a fair number of teens, and although we don't have a delayed school start here, we do write letters of medical necessity for them to start school later, because it really is a problem that's out of their control. Again, there can be a significant extrinsic component with the other distractors, and we try and get that under control as well. So let's move to case 2, and this is the opposite. This is an older woman, 2-year history of waking up early and feeling sleepy during the day. She's falling asleep by 8 p.m. Most days is getting up between 2 and 3 a.m. and usually can't get back to sleep or may sleep lightly. Ideally, she'd like to sleep from 10:30 to 6:30. And she was sent to the sleep center because she fell asleep while driving because of excessive sleepiness. So again, is this somebody who's just kind of bored and unengaged and falling asleep early, or is this a sleep disorder? This would be classic for an advanced sleep phase disorder. In this case, you're falling asleep earlier than you'd like to and waking up earlier. In both of these cases, when you leave people alone, they get enough sleep, it's just the wrong times. This one, advanced sleep phase, tends to be more prevalent in older adults. As you get older, your sleep phase tends to advance or drift in the other direction. It is more true with advanced sleep phase that this can be more altered by external factors, such as physical, decreased mobility. People can't get out as much. Psychosocial factors, if they're older, alone, don't have a lot of engagement. People might tend to go to sleep earlier because they're bored rather than an actual intrinsic resetting of their clock. One of the other thoughts, at least with some older people with advanced sleep phases, some older people actually have reduced melatonin levels. This is a study looking at less than 80 and older than 80, which shows this is melatonin levels in the cerebrospinal fluid, so the fluid surrounding your brain. Very older people in this study had significantly less melatonin, although that isn't always consistently the case. So how do you treat it? Basically the opposite of what you do for delayed sleep phase. For these folks, you want to activate them at night so that they can stay awake longer. So what do they get? They get the light exposure in the early evening. So 2 to 3 hours before typically going to bed, you would recommend light exposure. When we talk about light exposure, ideally it would be sunlight. That's the best light exposure, but that's not always possible, and it's not always possible around here in the evening. So there are light boxes that have a specific amount of light output, and you would, we have a prescription basically to sit, a foot away for 30 minutes, not directly looking at the light box. Also, exercise or physical activity in the early evening to alert people. Advanced sleep phases are easier to treat. It's easier to make yourself stay awake a little bit longer than go to sleep if you're not tired. And this comes into play when we talk about jet lag. So what's jet lag? Jet lag is probably something most people here have experienced, a temporary desynchronization between your internal circadian rhythm and the external time cues of where you're at. So to some degree, people experience sleep loss fatigue. Depending on how severe it is, they can have more significant problems. So what are the factors that influence the severity? The direction of travel is a big one. When you travel east, you induce a delayed sleep phase. So if you're going to Europe, okay, it's, let's say 4 p.m. or 5 p.m. on your time, but when you get there, it's 1, 2, 3 in the morning. You should be sleeping because everybody else is sleeping, but that's not what your clock says it is. It's more severe the number of time zones you travel. The West is the opposite. You're advancing your sleep phase. You go back this way, it's earlier than your brain thinks it is. Again, that's easier to deal with because you can make yourself stay awake longer. There's also just some inter-individual differences. Some people are more naturally night owls. Some people are more morning larks, and that will play a role. So how do we treat this? So it's when people think about it, it gets complicated. But again, the idea is basically you want to speed up the realignment of your circadian rhythm. You can't change it. Your circadian rhythm is your circadian rhythm, and where you are is where you are. But you want to try and get them closer together sooner. So when you're going east, again, you've induced a delayed sleep phase. So you have to think about, well, say, well, but I'm supposed to get late in the morning when I have a delayed sleep phase. But your brain doesn't think it's morning there. Your brain at 7 in the morning in Paris is really at midnight on your time. So you don't want to get late at midnight. That makes the problem worse. But in general, if you're going east, you're avoiding late in the early morning and getting as much as possible in the afternoon, early evening, opposite going west. You want to get morning light at your new destination and avoid evening light exposure. Melatonin just came up, again, with Dr. Satay. Can be used. It's not always effective. It's not a great sleeping medication. Again, you might use it when people are traveling east, not so much as a sleeping medication, but to realign the circadian rhythm. It needs to be timed appropriately. There is a role for using short-acting or a short course of a sleep medication, just to at least minimize your sleep deprivation. And again, the usual, avoiding excessive use of caffeine and alcohol, which don't make your sleep any better, no matter what the circumstance. And finally, we'll talk a little bit about shift work sleep disorder. So 20% of people in industrialized countries are shift workers. They, again, as we've talked about, have significantly higher accidents, work-related errors, increased sick days, and World Health Organization actually has classified shift work as a carcinogen. So many shift workers have higher incidence of many different kinds of cancers. The one that's been the most studied has been breast cancer. So why might this be? It's felt to be due to melatonin, or one of the possible roles is melatonin. Melatonin itself might have some anti-tumor properties, either directly or indirectly activating other pathways where it works as an antioxidant. So what happens when you are a shift worker? Your exposure to light at night, your light exposure increases when you're a shift worker at night, and what does light do? Light suppresses melatonin levels. So that's felt to be one of the mechanisms on how shift work might increase cancer rates. We're going to shift gears a little slide. Now we're going to move to obstructive sleep apnea, which is without a doubt the most common thing we see in the Sleep Disorder Center. And you know what he's going to say? He's going to say, I don't snore. And then she's going to tape it or put it on her cell phone and show us. So what's obstructive sleep apnea? So just for some definitions, apnea means not breathing. In obstructive sleep apnea, it has nothing to do with your lungs or breathing. It's your upper airway, and you're having some repetitive episodes of upper airway obstruction. Your brain will not let you stop breathing. That's not the problem with sleep apnea. The problem is that your brain will keep waking up to open up that airway. It's very brief awakenings. We don't even call them awakenings. We call them arousals. They're just 2 or 3 seconds. So many times people with sleep apnea feel like they sleep fine. So just to go over a little anatomy. So your upper airway is basically your nose to your vocal cords, the back of your throat. It's held open by muscles. In somebody with obstructive sleep apnea, that upper airway relaxes. And everybody, when you fall asleep, those upper airway muscles relax. In obstructive sleep apnea, they're narrowing down more. Sometimes they totally shut down or obstruct, but they don't have to. They can just narrow down. Your airway's starting to obstruct, though. Your brain doesn't like that. You're going to keep working harder and harder to breathe. Your brain will wake up. It will happen over and over and over again. As Dr. Satay said, we see people, this happens 50, 60, 80, 100 times an hour. They have no awareness of it. They don't snore. So what causes sleep apnea, or what are the risk factors for it? Probably a big part of it is your upper airway anatomy. People's airways are just shaped differently. Some people's airways are more prone to collapse than other people's. Some of it can do with jaw structure. Some of it can just do with the internal airway that we can't see. Obesity is a really big risk factor. Again, alluded to in the previous talk. This is a problem in children and adults for obstructive sleep apnea. Children get sleep apnea too, most often related to obesity. Just like you deposit fat on your hips, you deposit it around your airway. Makes your airway narrower and more likely to collapse when you fall asleep. It's more common in men, although postmenopausal status in women does significantly increase risk, so that postmenopausal women are almost equivalent risk as men. Alcohol makes obstructive sleep apnea worse. One of the many ways that alcohol worsens sleep is by worsening obstructive sleep apnea. I'm sure there are some people who have been told that they snore a little bit more after they've had a few drinks. And alcohol it's a muscle relaxant. It relaxes the upper airway muscles. So snoring is worse for the first few hours, and sleep apnea is worse for the first few hours until you metabolize out that alcohol. So what are the symptoms? So breathing disturbances during sleep are the kind of obvious main symptom. What do people report? Well, the patient doesn't say anything. They don't snore. Bed partners, loud snoring, often heroic. They sound like a freight train. We hear these things. They may observe pauses in breathing. It's very frightening to bed partners. I don't know if any of you have seen that. Usually a bed partner is afraid that the person's not going to breathe again. Again, that's really not the issue. That's really the most basic thing your brain does is keep you breathing, but it is scary to watch it. Occasionally people are aware of waking up gasping or choking, although that's not very common. That's less common than the other two. Difficulty maintaining sleep. So sometimes people feel like they sleep fine. Other times they might feel like their sleep is disrupted, but they're not really aware why, because by the time you wake up enough to realize you're awake, the sleep apnea part's gone. Excessive daytime sleepiness, another big symptom. So what's that? Falling asleep unintentionally, watching a TV show you like, falling asleep in a meeting, falling asleep driving. More vague things, fatigue, irritability, memory difficulties. Morning headaches, not specific for obstructive sleep apnea. We see it with sleep deprivation in general, but often people with sleep apnea wake up with a headache. What if you don't have a bed partner? People come to us because they feel like their sleep is poor or they're tired during the day. They really just don't have any awareness that this is something that they would have. So why do we care about sleep apnea? Well, a major issue is quality of life. As we've talked about, when people feel like either they don't sleep well or they sleep and the quality of their sleep is bad, their quality of life is bad. It can impact them socially. You may be too tired to engage in activities. It can impact your performance at work. So a huge consequence of untreated sleep apnea is quality of life. There's another piece to this, though, in that research over the past probably 10 years has really shown a link between obstructive sleep apnea and cardiovascular diseases. Pretty clear increased risk of high blood pressure, associations with heart disease, with stroke. More recent research associates sleep apnea with diabetes. It's not necessarily causative, but they seem to be associated at this point. Increased risk of accidents. Studies showed up to 7 times greater risk for car accidents with sleep apnea. And again, as Dr. Sate talked about, the airlines and the trucking industry are very on board with this. And if you're a truck driver now and you have a big neck and you snore, they send you for a sleep apnea evaluation before they'll even think about renewing that commercial driver's license. It's that important in terms of accident risk. So how do we diagnose it? We do a sleep study. And I promise I won't make you know all of this or quiz you on it, but basically what we're doing is we want to see what your breathing is doing when you sleep. So we stick on a whole bunch of wires. They're all pulled into one bunch, so it's uncomfortable, but there's no needles. They're all kind of in one bunch, so if you have to get up, it's okay. And what we're looking at is a number of different parameters. We're looking at some eye movements. That's how we can tell if you're in REM or rapid eye movement sleep. We're looking at, these are some brain waves, your cardiogram. This is a microphone in the room that picks up snoring. This is looking at flow. So there's a little thing across your upper lip that can detect airflow. And then these things are actually kind of Velcro belts around your chest and your abdomen that look to see if you're trying to breathe. So if you're trying to breathe and not moving any air, you're having an apnea. It's a little hard probably to see, but what is happening here is this is 30 seconds. This is a standard, what we call an epoch, or how we look at sleep studies. This is 30 seconds. This pause is about 15 seconds. It ends with a big snort, and the brain waves speed up a little bit. And that will happen over and over again. This is a more compressed picture. This is actually from one of our sleep lab patients. The name's gone. But what you can see is this. This is a 5-minute window. So this is in 5 minutes. This happened 1, 2, 3, 4, 5, maybe there's 6, 7, 8 times. So that's more than once a minute. So what do we do for sleep apnea? It's actually treatable. People feel a lot better when we treat it. Well, you know, if it's really mild, then people can do what we call conservative measures, things you can try on your own. So working on weight loss, avoiding alcohol close to bedtime. There are some surgical procedures for sleep apnea. They're not particular. The standard surgeries are not particularly effective. They basically involve going in the back of your throat and taking off the uvula. That's the hangy thing in the back of your throat, and the soft palate above it. It opens up your throat. That's the place where the snoring sound comes from, so that tends to get better. But sleep apnea is actually more of your whole airway is a little unstable, so more than half the time the surgery doesn't work, it hurts. And you can't predict which people it will work for. So actually the surgeons at our institution don't really do it a lot because it's not very effective. The other options are an oral appliance, a custom fit oral appliance, and CPAP. And I bring props when I do this, so I'll show you some of these. But what we use most of the time is CPAP, and I'll tell you about that. And we also use these oral appliances. So what's CPAP? CPAP is a little machine, continuous positive airway pressure. This is a CPAP machine. It's a fake one, but it's basically an air compressor. It's just kind of a fancy medical one. It takes room air. It's not oxygen. It just takes the air you're breathing. It pressurizes it. You breathe in that pressurized air, and it just holds that airway open so that it can't collapse down. Very effective. It's really straightforward. Works 95% of the time. No dangerous side effects. You got to get the air from that thing into your airway, so you have to wear a mask. So I brought a couple of the more benign looking ones. So there's nothing special. One mask isn't better than another one. You got to get air from there to there. So whatever does it for you is fine. But a lot of them just fit right over your nose. They have to strap on. They have to attach. This is pressurized. If it would blow off your face if it wasn't held on with straps. This is just one that goes over the nose. This is one actually that is called nasal pillows, which sounds so nice. And that actually just goes right up. It's soft. It goes right up into your nose. And there are ones that actually cover the nose and mouth. There's a hose. I didn't bring the hose, but the hose connects it to the machine. There's a swivel thing on it. You don't need to kind of lay stock still. You can move. And again, we do a sleep study with the CPAP. We figure out what pressure you need to hold your airway open. And it's very effective. And in the end, people look at that and they think, no way. But most people actually really do well. They really feel like they sleep better. They feel better. Data is starting to come out about improvements in blood pressure, certainly quality of life improvements. It's a little bit harder to prove cardiovascular improvements because the cardiovascular risk builds up over time, so probably using CPAP for a couple months isn't going to change that immediately. Another option is a custom fit oral appliance. So the key to this is custom fit, not the ones you get from TV or the internet. You want to go to a dentist who knows what you're doing. I actually have one of those as well. There's a few different ones. This happens to be this one. It's called a Somnodent. But the idea of these is they pull your lower jaw forward, and that opens up that back airway, stabilizes it. These work about 80% of the time for milder sleep apnea. The more sleep apnea one has, the less likely it is to work. But we have a number of people who use them effectively. And anything that works for sleep apnea will work for snoring too. So those are a couple of the more popular treatments that we use for sleep apnea. And again, sleep apnea is definitely the most common thing that we see. There's probably, there have been population studies that shown at least 2 to 4% of the North American population have significant sleep apnea. That's millions of people. That's probably about 18 million people. Again, another common thing that we see. So what is it? It's subjective. There's not a test that we can do to say you have restless leg. Restless leg is a subjective, disagreeable sensation. People describe it as a creepy, crawly feeling. It can be pain. There are variations on how it can be described, but the most common description is a creepy, crawly feeling, most often localized to the calves, although people can feel it kind of ascend through their body or come in through their arms. There's a circadian variation to restless leg symptoms, and they are most bothersome in the evenings at bedtime. So when people are trying to relax and get ready to go to sleep, they get this jumpy feeling. They actually have to move around. So movement, stretching, often people actually have to get up, walk around. It can be so distressing that people are near suicidal because every time they try to get to sleep, they have to get up and walk around. Complaints of evening distress, difficulty initiating sleep, disturbed sleep. For many years, people kind of know about restless leg now a little bit more, and they advertise medication for it on TV, so everybody knows about it now. But for many years, people really didn't know what it was. Often people would go to their doctor and describe this, and they're like, I don't know, sort of ignore it. And there's actually really effective medication that treats it. And we would see people with a severe restless leg, give them a tiny dose of this medication, and after 20 years, it's gone. So it can be extremely bothersome. So again, we can't do a test to diagnose it. It's totally subjective. It's you telling me this is what's going on. So what are some clues to it? What are things that are associated with it? Probably the biggest association we see is an iron deficiency. No one knows exactly what causes restless leg, but it seems to do with how your cells use iron. So when you have low iron levels, so low that you actually have an iron deficiency anemia, it's much more common. You don't even have to have low iron levels. You can have low ferritin levels, and ferritin is the protein that carries the iron around in the bloodstream. And really, the only effective lab test we have is we can check people's ferritin levels, and if they're below a certain level, then that's something we can target with iron. Even if they don't have iron deficiency anemia, this suggests that they could use a little more iron. More common in pregnancy may have to do with the iron utilization. We also see an advanced kidney and liver disease, again, has to do, you might not actually have a low iron level, but the way you're using iron isn't the way that your cell needs it to be used. Importantly, the use of certain medications, almost all the antidepressant medications increase the risk for it. There's one antidepressant that doesn't, but the rest of them all have a side effect of increasing just motor activity in general. And where we see that is with restless leg, people feel like they have to move their legs. When they're asleep, we see them have more leg twitches, repetitive leg twitches. They don't know they're happening. We actually see them have more eye movements when they're asleep. Another big place where we see it is a family history. So how do we manage it? Very important. You only need to treat it if it's impairing your quality of life. So we talked about with obstructive sleep apnea. There's other reasons to treat sleep apnea. Certainly quality of life is a big reason to treat sleep apnea. However, there's cardiovascular risk associated with sleep apnea. So if people have significant sleep apnea, or think of other diseases, high blood pressure, you may feel fine from high blood pressure, but we know that if you have high blood pressure for a while, it's important to treat it because it can impact the rest of your life. Restless leg, there's not any other health outcome with it. It's just really annoying. So if it's really, really annoying you and really impairing your quality of life, it's worth treating it. How do we treat it? So again, treat the underlying condition if you can. So if there's anemia, treat that. Supplement iron if ferritin is below a certain level. Avoid caffeine. Caffeine tends to make it a little bit worse. Review medications that may be worsening the symptoms, including the antidepressants. And if nothing else, if you've gone through all this, you still have it, it's still really bothersome, there are medications that can be used. They're very effective. We can use usually very low dosages of a medication at night that can very effectively take care of the problem. In summary, as both Dr. Satay and I have talked about, sleep disorders are common. They can have profound impacts on your quality of life as well as other health consequences. There are effective treatments available for the majority of them, which can improve quality of life and other health outcomes. And when we talk about the circadian rhythm disorders, they can be treated, but it is crucial to time light and melatonin correctly, or you can make the problem worse. So I think that's all I have.
Thank you.